I like to summarize my presentation in one sentence. And the summary of this presentation is that your antithrombotic strategy is as important as your vascular strategy and your endovascular strategy. When I was graduated 40 years ago, we only have 1 or 2 drugs. So antithrombotic and CLI, and it's a very tricky road ahead. I will try. It's the end of the session. I don't like to cross my time limit, so I'll try to walk you through. Definition of CLI must be categorized. Very important that you have a drop in the ankle breaker pressure index with symptom more than 2 weeks, which we all know, and these are the criteria of CLI. The guidelines have changed dramatically. We started by task 1, and then task 2, 2007, and then at 2011 we have the European Society of Cardiology recommendation. Now we have at 2016, there are the combination of ACC and AHA guideline, and even 2017, European Society of Cardiology with the European Society of Vascular Surgery have their guideline. This is the latest, 2017 in September. Not only that, but even the anticoagulation drugs are rapidly changing. You can see the oral medication and the injectable medication are rapidly developing in the last few years. The anticoagulation cascade also has been rapidly developing. We have now the anti-factor 10, which is the indirect factor inhibitors, and we have the direct inhibitors, and we have the direct thrombin inhibitor, like fondaparinux, endaparinux, and rivaroxaban, and apixaban. So you can see the amount of drugs being put in. Starting 2018, we'll have anti-factor 8 and anti-factor 7. So this slide will dramatically change. Even antiplatelets, we used to have 4 types of antiplatelets. You have the aspirin, the well-known, and you have the P2, Y12 receptor blockers, like clopidogrel and prasugrel, and also you have the reversible one, like ticagrelor. You have the GB2, 3A inhibitors, either monoclonal or synthetic. So you can see the map of antiplatelets are also rapidly changing. So you have 3 things moving at the same time. You have a changing guidelines, you have a changing of drugs, and you have a changing of treatment. What can we do? This is the puzzle. This is the amount of literature that you can see comparing the antithrombotic treatment. You can see the amount of paper. I've tried to put the fundamental of this paper. So here you have the paper comparing ticlopidine with aspirin, clopidogrel with aspirin, and the other arm is only aspirin alone. And you have the clopidogrel plus aspirin, and these are the amount of papers that is found in between of them. You also have sometimes between side arm, like ticlopidine and placebo. So these are the data that I want to summarize for you to have the standard. So you have to read a lot of fundamental paper, like Capri trial. I wouldn't go into the detail, but these are the mother trial of the anticoagulation, was done over 20,000 of patients. It wouldn't be repeated again. And the Capri trial have concluded that the result indicate that clopidogrel is more effective than aspirin alone, which is a great lesson that we have taken into consideration. These are the arm of aspirin and clopidogrel, and these are the 36 months follow-up, and you can see the risk-related reduction in this paper. Now, one of the other paper is EUCLID study, which is the studying of ticagrelor in peripheral arterial disease, which is one of the remarkable study. As well, it also concluded that patient with symptomatic peripheral arterial disease, ticagrelor was not actually better than clopidogrel. It wouldn't be repeated again. You can see it was done over 13,000 patients with 3 years follow-up. This is the design. I wouldn't go into the detail. And this is the Casper trial. Again, one of the major trial in the antithrombotic medication to PED. And it showed that, I will go quickly, it showed that in Casper trial that dual antiplatelet therapy with clopidogrel and plus aspirin did not significantly reduce the primary endpoint of occlusion. of revascularization procedure, above the knee amputation or this in patient with PED. One of the last of these is Charisma trial, again comparing antithrombotic medication to our patients with PED, and it did patient benefit beyond the 1 year plus ischemic result, and they will use dual antiplatelet therapy. This is the Charisma trial. So my conclusion, out of these 49 major trialed antithrombotic treatment with rapidly changing guideline and rapidly changing modality, is the following. That single antiplatelet therapy is recommended after infrainguinal bypass surgery. It is essential and it makes a big difference in your result of your patients. And patients require antiplatelet therapy, clopidogrel may be preferred over aspirin. And vitamin K antagonist may be considered after autologous vein infrainguinal. These are the guidelines by ESVS 2017. And this is a very nice paper. If you put efficacy and safety of each of the drug, you can find that the best is clopidogrel so far. The highest in safety and the highest in efficacy. So this is again is a good lesson. So let us summarize. The summary of my recommendation was from ESVS at September 2017, antiplatelet therapy in patient lower extremity disease. It's like the Bible that we follow nowadays, which is going to be changing in 6 months. So you either differentiate into symptomatic or revascularization, and this will be percutaneous or surgery. If you are symptomatic with peripheral arterial disease, single antiplatelet therapy for 1 year or even more. If you have percutaneous, for 1 month, you give double antiplatelet therapy, and after 1 month, after that for 1 year, single antiplatelet therapy. Regarding surgery, it is single antiplatelet therapy from the start. These are the last guidelines regarding PED. If you have a patient already on anticoagulant, like patient with atrial fibrillation, these are the last recommendation. You have either asymptomatic or surgery, and this you need oral anticoagulation, monotherapy, or if you have percutaneous intervention to patient already on anticoagulation, you use double antiplatelet therapy for 1 month, is essential, and after 1 month, either you go double antiplatelet therapy or oral anticoagulation. If bleeding risk is high, then you start oral anticoagulation only. Now, this guideline is going to change. It's not constant, as you have seen, and it was published before the result of COMPASS trial. Now, the COMPASS trial is a very important trial because it showed, just the conclusion, that rivaroxaban 2.5 milligram BD plus aspirin seemed to be as good as anything. So they didn't include the result of COMPASS trial in the guidelines, and I would think it will change very quickly. A lot of practitioners started to have rivaroxaban 2.5 BD as one of their standard regimen, but it didn't jump into the guidelines so far. This is a COMPASS trial design. They said, well, let us give patient rivaroxaban or new oral anticoagulant. Let us give another arm aspirin and another arm rivaroxaban plus aspirin. These are the three modality, and they found that the best one is rivaroxaban plus aspirin. This it showed to be have the best results. So I will just jump to my conclusion. Future of antithrombotic treatment in CLI is very interesting. I used to give this lecture every couple of years, and each time it changed about 80%. It is rapidly changing field, and we must use drugs. It is as strong as our knife or our CTO wire. It's not less than them, and it is rapidly changing. With discovery of new antiplatelet, new anticoagulation, the safety profile will be increasing, and the guideline will be rapidly changing accordingly. And thank you very much for your time.